Welcome to The Doctor Will Hear You Now, a podcast featuring our physicians and other healthcare providers telling their stories, sharing glimpses into their daily work and mission, and showing what it means to practice medicine just a little bit differently. Healing you means hearing you, so let's talk. I'm Ben.
And I'm Lexi, and today we're joined by Dr. Mary Raven, the Medical Director for the Palliative Care Program at Our Lady of the Lake Regional Medical Center. She's board certified in both internal medicine and hospice and palliative care. Hey, Dr. Raven, thank you so much for joining us today.
Hey, thank you for having me.
Of course, we're so glad you're here. Can you kick things off with us? We'd love to learn more about you and the work that you do for Our Lady of the Lake Health.
Okay, I am a small town person. I grew up in Rayville, Louisiana, a little bitty town near Monroe in Northeast Louisiana. Come from a big family. I'm one of 6 kids. Most of my family I say most, some of my family went the law path, but I kind of knew at a really early age that I wanted to be either a nurse or a physician. And as I got older into high school, when you realize, well, wait, I can be a physician. I think I have the aptitude to do it. I was lucky because I always knew leaving high school what I wanted to do. So I set on a path and really never deviated from it. I moved down here to Baton Rouge, went to LSU for undergrad, went to medical school at LSU in New Orleans, and then came back to Earl K. Long, which doesn't exist anymore, but trained at Earl K. Long in North Baton Rouge. Stayed there for several years and then started here at the lake. So I've really been in South Louisiana since 1996. A lot of people ask me, how did you get into palliative care? I started at Our Lady of the Lake as a hospitalist around 2008, and I really love that work, taking care of patients who are sick, getting them through their hospitalization, hopefully to safety, and then discharging them so they can follow up with their outpatient physician. And I enjoyed and I still enjoy taking care of people while they are sick in a hospital setting. So it was a good fit for me. Early on, when I was doing hospital medicine, I would find that there were certain patients, usually really sick patients, who would come in and out of the hospital repeatedly, often for the same kind of problem. It became clear that their families, who at this point are oftentimes really involved and trying to make the best decisions they can, they did not seem to me to have a real clear understanding of why all of this was happening. So I would find myself sitting down with families, asking them, for example, what do you understand about dementia? Has
Mhm.
anybody ever talked with you about what that really does over time and what the natural course of that is? And you would usually find that they didn't really know. So I'd spend lots of time educating them about the illness, and then things would make a little bit more sense. It seemed to me people were able to make better decisions about their loved one when they fully understood what was going on. I enjoyed that aspect of it, educating patients and families, sitting down, really listening to what they knew, and then helping them perhaps make some different decisions. Around that time was when my partner, one of my partners, Dr. Mark Cantrow, was beginning the palliative medicine service here at the hospital, and he was by himself with one of our nurses and getting super busy. He and I became friends. I really admired what he was doing because when we would consult him, somehow he was able to really get people to move from point A to point B in a way that I didn't understand how to do that yet. He sort of became my mentor and said, "Look, I need some help. Would you like to come over here and work with me?" Within a couple of years, I was working half time with the palliative medicine service. Then I became board certified in 2012, and I've just done this full time ever since. My passion for palliative care, I think, just comes from the need that I saw early on and the reward you get when families really feel a little bit more at peace. Even when it's difficult, at least they have some foundation of understanding. That's sort of why I ended up in palliative care.
Yeah, that's good to hear. Good to hear that background from you. I guess maybe to step back a little bit, if you could, for the people who might not be familiar with palliative care,
Yeah.
explain a little bit about what that specialty is and why it's important in a person's care.
Yeah, the word palliative comes from the Greek word pallium, which is a term for cloak. Palliate means to alleviate suffering of any sort. So, palliative care as a medical subspecialty is specialized medical care for patients and their families who are living with serious illness. In my world, the family unit is really the unit of care. It's not just about that person who's got an illness, it's about that person his or her loved ones, including spouses, children, because most of the time, especially in the hospital, when palliative care is consulted to see a patient, that patient is very, very sick. And they often are not able to comprehend or understand what's going on anymore around them. So we rely on the families to help make decisions. Essentially, palliative care is taking care of patients with serious illness in an effort to improve quality of life and alleviate suffering for both the patient and the family.
Yeah, thanks for walking us through that. I think it's likely people who maybe haven't had family members who are ill or seriously ill yet may not have come across the specialty. Just walking through it and explaining it, I think is really helpful so that they are aware that that is especially in a resource for them if they ever do enter into that a situation where they would need to know. I'm curious about you and your, I guess, daily routine. What's a typical day look like for you? Is there a typical day?
Not really. It's always a little bit different, but in general, at least our service at our hospital, Our Lady of the Lake, palliative care has three major realms in which we operate. The majority of what we do right now is inpatient consultations within the hospital. The second piece is we have an outpatient practice. So we opened up a clinic in 2014 where we help patients who are upstream of the end of life crisis, right? These are patients we
Mhm.
get the opportunity to get to know while they're living with an illness like cancer and while they're in the throes of treatment for cancer. We help with a lot of pain management, a lot of psychosocial support, just doing some advanced care planning with these patients, trying to help them have the best quality of life they can as they're getting treatment for their illnesses. A third little spin-off of our service is we have a multidisciplinary ALS clinic that Our Lady of the Lake sponsors. One of my partners, Dr. Lon Pham, is the palliative care physician there. So we have really three different main avenues where we work. My typical work pattern is 1 week out of my month, I'm in the clinic every day, Monday through Friday. And then about 3 weeks out of the month, I am in the hospital doing inpatient work. When I'm in the clinic, it's a different feel because our patients are at a different point in their life. It's a lot of pain management over there. In the hospital, even in 2023, when palliative medicine is consulted to see a patient in the hospital, it's often because people are not doing as well as we hope. And
Mhm.
we're having to navigate decisions about things like feeding tubes, the use of life support, whether or not that's in the person's best interest. And if it's already been started, is it accomplishing the goals that we had hoped? Sometimes it's just helping people figure out where they go when they leave the hospital. Is home still a good environment, or do we need to move to a nursing home? Is hospice really the next step? It's a lot of counseling patients and families through these types of treatment choices oftentimes at the end of life. So that's the weeks that I'm on the inpatient service line. I mean, I pretty much get up every morning really early and then I get to work early because I like to just kind of look at my list of patients for the day. We are a team. Palliative medicine is a team sport. So it's not just
Mhm.
about a physician or a nurse practitioner. It's about our social worker who participates in our team, our chaplain who participates in our team, our nurse. It's an interdisciplinary group of people who get together, and every morning at 8:30 we huddle and talk about our patients. Everybody's got something to contribute, and each person's contribution is equally important. We have a huddle for about an hour in the morning, and then we go off and we see our patients. And sometimes it's managing pain, sometimes it's sitting down and having big family meetings to talk, to share information, listen to concerns, and then help people kind of get some guidance through what can be pretty rough terrain if you've not ever had a loved one in the hospital before.
You brought up hospice care, and that kind of brought up a question I had, which was that transition, I guess, between palliative and hospice care and the differences. I was curious if you could kind
Yeah.
of help explain that a little bit better.
Yeah, I think I probably explained the difference between palliative care and hospice 25 times a day because let's pretend your mother has had a stroke and she's in the hospital and you've been sitting there at the bedside watching her and the team comes in and they say we're going to consult palliative care. You probably don't really know what palliative care is. You may or may not have heard that term before. So you're going to do what? You're probably going to get on your phone, you're going to Google what is palliative care, right? And you're going to probably see hospice. You're going to see palliative care and hospice. They're closely linked. My board certification is in hospice and palliative care. So the two terms are very closely linked. There's some similarities, and that's because hospice is a form of palliative care. Okay.
Mm.
It's palliative care for patients who are in the terminal phase of their illness. What is the terminal phase of an illness? That's getting to be a little bit more and more of a gray area and sometimes hard to identify. But Medicare, who pays for hospice care, has guidelines around this. So, to qualify for hospice care, two physicians need to be able to look at your situation and say, I think this person could die within the next 6 months if this disease takes the natural course. To qualify for hospice, you by definition are someone who likely is in the final 6 months or so of life and who has opted to take the approach of just wanting to focus on quality of life over and above length of life. Meaning, I'm focusing on what I need to do to have some comfort, but I'm ready to let go of some life prolonging treatments. The big example is if I have cancer and I've reached a point where the chemotherapy is either creating way too much toxicity for me or it's just not helping my cancer anymore, I may choose to let go of that. I may choose to say, I'm not doing chemo anymore. I can accept where I am. I want to be comfortable and I want as much care as I can during that time frame. That's where hospice plays a role. And I always tell people hospice is just a word. Sometimes I'm having meetings and hospice comes up and I immediately look at people's eyes because I'm either going to get dirty looks
Hmm.
like I don't want to hear that, or some head nods like, yeah, my mom went through that and it was a good thing. So people are very polarized and opinionated about hospice. And that's just because it's about the end of life. And by nature, as human beings, don't love to talk about it. We want to pretend like it's never going to happen.
Yeah.
And to bring it up almost makes it occur. I think subconsciously we believe that. So I try to detoxify that a lot with patients and families and say hospice is a great thing at the right time.
Hmm.
And none of us are in here to push you into that unless you're ready for it. So, hospice is a form of palliative care for people in the final phase of their life. Palliative care is simply care devoted to alleviating pain and suffering. And that doesn't depend upon your prognosis, right? We're providing palliative care to patients when we treat their pain postoperatively. That's palliative care too. We're providing palliative care when we're sitting down with patients and families and saying, listen, tell me what you understand and tell me what's most important to you right now. We all provide a little bit of palliative care, and you don't have to be a palliative care physician to do that. Does that make sense as far as the differences and the similarities?
Yeah, it definitely does. I'm glad we talked through that because if we have listeners who maybe haven't reached that phase yet in care with a loved one or themselves, hearing that and then Googling it and seeing hospice pop up, I can assume would be very scary. So hopefully we're able to reach people to put them at ease and just understand the difference going into any situation. You talked a little bit about meeting with families and sitting down and connecting with people. Are you able to offer video visits for patients and families? How does technology play a role in how you care for people today in 2023?
Thankfully, video visits really got ramped up for us a few years ago. Even before COVID, we were doing
Mhm.
video visits in our outpatient clinic. And as we all know, when COVID hit, video visits became even more important and everybody really had to do them. But we knew early on we're going to start taking on this population of patients in our outpatient practice who are dealing with advanced cancer.
Mm.
Oftentimes, it's not easy to get to a doctor's office frequently. You may be feeling nauseated that day. You may be having trouble with ambulation. We knew that we had a very vulnerable group of people we would be taking care of, and to be able to offer the chance to just stay at home, let's get on a video visit and let's just talk about your symptoms. We've been doing video visits for years. We find them to be incredibly helpful. A lot of what I do doesn't necessarily require me to do a physical exam on a
Yeah.
patient. I'm usually just listening to concerns, talking about pain and prescribing medicines. And that can easily be done through video. And our patients love it. It's so convenient for them. Many of them are coming back and forth once a week at least to their oncologist already or their infusion appointment. To be able to save them a trip has been really nice. So, yeah, we do video visits all the time.
We've talked a little bit about listening in the work that you do, and obviously it's a big part of all the work that we do in our health system. I know it's especially interesting thing to navigate with palliative care because you're dealing with the patient and their needs and their desires, but also family members around them who might want to contribute or might know a little bit about their health histories. I'm curious just how listening works in your day to day with these patients and their families.
One of the things that we have in palliative care that is a luxury is the luxury of time. In my clinic, for example, we don't see 20 patients a day. We see 10 or 12 patients a day. Our clinic visits are purposefully long so that we can offer that to patients. I'm amazed with primary care physicians and other specialists who are moving through and seeing so many patients a day. There's just not the time they need to be able to say, listen, tell me what you understand. What are you hearing the physicians tell you? And then I say nothing, right? I shut up and I let them talk to me. That may take 5 minutes, it may take 30 minutes. We are lucky in palliative medicine that we're able to give people that kind of time because that's really the therapy, I think. Oftentimes, when you take a moment to listen to what people really know about what's happening to their bodies and what's happening to their loved ones, they'll tell you themselves. It may be the first time that they've even said it out loud or admitted it to themselves. I'm watching this person go through this and I'm worried. I'm
Mm.
worried about where this is headed. You've got to be able to shut your own mouth and let people tell you these things for it to rise to the surface. In the clinic, we schedule long appointments. A new appointment is an hour, a follow up appointment is 30 minutes for us. So that's generally enough time to allow them to be heard. And in our hospital work, it's a similar thing. I'm not rounding on 20 patients a day unless it's 2020 and it's COVID-19. That was a nightmare. We give people the time that they need. We may have a family meeting that takes 90 minutes in some cases.
Mhm.
So, listening is the biggest tool we have in palliative care that helps us get patients through these challenges that they're in.
It's
I think
group work too, right? It's a special kind of listening that isn't just the one on one, it's a group setting.
You make a good point. I mean, in a family meeting, the patient may or may not even be in the family meeting because he may be intubated on a ventilator, right? There are usually multiple relationships going on, and you learn a lot just by listening to people chime in. We see the good, the bad, and the ugly. When it comes to serious illness care, we see highly functioning families who are doing really well, and then we see fragmented families who struggle, really, really struggle. It's interesting to watch those dynamics play out.
I'm sure it is. I think what's so interesting about what you're describing in palliative care is that listening is really your main tool for treating that patient or helping them along the way, which I think is a lost art maybe in other specialties in medicine too.
Yeah, I think we're all getting better at it. Palliative medicine physicians learn things from cardiothoracic surgeons who learn things from critical care physicians, and we learn things from our general surgeons and nephrologists. And all that creates your culture in your
Mhm.
hospital is these different personalities, different specialties, and the way that we teach each other. I've seen myself in the 12 years I've been doing this that our hospitalist service, for example, is really good. We have a very strong hospitalist service, and they do really great goals of care discussions too. So I think we all can learn from each other, and I think
Mhm.
as we move into the future, palliative medicine, the role for someone like me or a Dr. Cantrew or a Dr. Pham is educating and creating this basic palliative care skill set that we all really need to have. I think that we all learn from each other constantly and we get better. We get better as a result of that.
I want to go back a little bit. You talked about listening to multiple people and hearing them. And you mentioned this a little bit before too about advanced care planning. And that is a big part of listening, I would say specifically to what the patient wants and the plan that they have for their end of life treatment and care and what that looks like for them. Can you tell us, for our listeners who may not know, what advanced care planning is and why it's important for everyone to consider, even while they're healthy?
So, National Healthcare Decisions Day, April 16th, is really about trying to promote advanced care planning to the community. What is advanced care planning? Well, advanced care planning, I've described scenarios in my daily life at my work, right? I'm meeting with families of patients who are intubated and on life support because we want to know, is this what this person would have wanted? And if so, for how long? Those conversations are much easier to have with families if that patient has expressed his wishes in advance.
Mhm.
Those conversations are really hard for families when they have no clue what the person would have wanted. And then they feel the burden of those decisions. They feel guilt. They feel like they're going to question themselves. It's always easier if a person has ahead of time, ahead of some serious or terminal situation, if they've said, listen, here's what makes life worth living for me. And if these types of things were to happen to me, I'm okay with going, and I don't want you to prolong my life artificially, for example, with feeding tubes and life support machines. Understand that there's a lot of gray area there, and I know that this is not a black and white world. It's hard to make too many decisions too far in advance. For example, if I'm 25 and I start saying, I don't want to be resuscitated and I never want to be on life support, well, that's a little too much decision to be making at that young time in your life. You don't know how your life's going to evolve. You don't really know what medical scenarios you're going to be facing. So I don't encourage
Mm.
healthy young people to make too many granular decisions, but at the very least, you should designate a healthcare power of attorney. That means you're just designating a person to make decisions for you if you can't make your own decisions. If you're incapacitated and you cannot comprehend the information coming at you, have someone you trust who knows your values, who knows your personality, who can be willing to make some decisions. Everybody, no matter what your situation is or how old you are, if you're an adult, you should have someone designated to make your decisions. If you don't do that, then it will be your spouse if you're married. And if you don't have a spouse, it will then be your children. If you do not have children, it will be your parents. And if you don't have parents, it will be your siblings or anyone else related to you. So there's a method that we go around if we don't have any form of advance directive. But sometimes that's the right method, and sometimes it may not be the right person. For example, if you're separated from a spouse and you've not lived together for 25 years, but you never got a divorce,
Mm.
and you've got a new boyfriend who you've been with for 5 years that you love and trust, if you get into a crisis, guess who your healthcare power of attorney is? It's your separated husband that you hadn't been with in 25 years. Is
Mm.
that the right person to make your decisions? I don't know. But if you know that hierarchy in advance and you know the sort of the ramifications of not doing an advance directive, you might say, hey, wait, let me go ahead and make this person healthcare power of attorney so they have the legal right to speak on my behalf. That's a huge part of advanced care planning is just designating someone to help make decisions for you should you ever become incapacitated and having a conversation with that person about what you would or would not want. It can be a general conversation. It at least gives that person some guidance as to what to do. There's also a living will. That's the other sort of standard form of advance directive. And a living will basically is you saying, okay, if I'm in a terminal state, I do not want ongoing heroic measures to keep me alive, including nutrition or hydration. In Louisiana, they make you have two different options. One includes nutrition and hydration, and the other one does not. Living wills are helpful too, but I would encourage people to do that a little bit later. They
Mm.
get a little bit older and a little bit more aware of what's happening to them medically. That's advanced care planning, and I encourage everyone to at least get a healthcare power of attorney, express some opinions about what you would or would not want. If you were to have a brain injury, for example, or just be so sick that the doctors were worried that you may not improve.
That's great advice and actually brings up, I guess, another spin-off question of that is your wishes may change as you move through life, right? As you have kids, you may say, I want to do everything I can to stay alive because I want to make it back with them. Or as you get older, it may be, I don't want tubes or feeding devices and things like that. How frequently should you be having these conversations with your power of attorney? Because it changes as your life changes. And so, would that be yearly? Would that be every few years? What do you recommend?
That's a really good point. Your values and your goals for your care definitely can change as your life circumstances change. You may say when you're 25, I never want to be on a life support machine. Well, then you get married, you have children, you're like, well, hang on. Maybe I do want some of these things if there's a chance I can come back and have some meaningful
Hmm.
time with my family. So it may be good every year to relook at your advance directive and say, is this person that I made my power of attorney still the right person? Or maybe you're older or you have some serious illness. okay, is this still how I really feel about things? Has my quality of life changed in some way that may make me feel differently about the use of heroic means of sustaining life? It can take you 2 seconds to answer that question, or it may take some changes. But I think each year is probably a good idea just to make sure everything's in order. By the way, having conversations with your physician about all of this is really important too.
Mm.
It's one thing for you to know your wishes and your power of attorney to know your wishes, but if you land in an emergency room and that's not in your medical record at all, we have no idea that those conversations have ever even been had. Your physician really should serve as a conduit to be able to get those wishes in your medical record where they need to be. If you've got your living will in a safe deposit box, that's not gonna help your doctor or nurse or EMT that's been called to come see you. They'd have no idea that you've even done that. Making sure that's translated into the medical record is equally important.
Definitely. I think one more question before we move on from advanced care planning. How do you formally designate a healthcare decision maker or power of attorney for your healthcare decisions? I'm sure there's a formal designation process. You can't just say, I choose you, and then everyone knows. So, how does that work?
There are legal forms that you can use within our healthcare system, and most healthcare systems have some form of advanced care planning booklet for you. We definitely have a well written advanced care planning booklet that has both a living will and a healthcare power of attorney in it. And it's got some pages that educate you around some of the terms you're going to read and why this is important. Within our healthcare system, it's a matter of asking your physician if they have an advanced care
Mm.
planning booklet. You can probably also go online and Google healthcare power of attorney, and I'm sure you can find a document. Here's the truth in Louisiana: you do not have to see an attorney to make this official. Some people think, oh, well, I can't afford it. I can't afford the legal fees that are involved with creating these documents. You don't need an attorney to do this for you. And you don't even have to have these documents notarized. You just
Mm.
have to have 2 people witness the document, and they need to be 2 people who are not really related to you. The way the language
Mm.
of the law speaks is they cannot be 2 people who stand to benefit from your death. Get 2 friends to witness your document, you date it, you write out your wishes. I mean, that's literally all you'd really have to do, but you can find forms. So, 2 witnesses and then bring it to your doctor would be the way to do it.
That's fairly simple and doesn't sound too expensive. So, everyone, go and do that now.
Yeah, that's good advice for sure. You don't want
Yes.
someone just showing up and saying, "Ben told me that I'm in charge of his healthcare,"
Right.
you
I
know?
wouldn't be able to do that. I'd like to, but having it in writing is really helpful. And again, if you don't have anything like that done, then we're going to immediately start looking for either the spouse or the children or the parents, and we would use them to help make decisions.
I wanted to touch on some personal stories, patient stories that you can recall where you're speaking with the patient and the family and listening and having that discussion really does help them with these end of life decisions.
There have been so many over the years, but one of my most recent experiences that was rewarding, and this was just a few weeks ago. It was actually a personal friend of mine. Her dad was struggling with stage 4 lung cancer and had really done quite well under the circumstances. They called him a cat with 9 lives. He's one of these hardworking farmers who had open heart surgery years ago, battled through that, still stayed super, super active, and had been living with stage 4 cancer, going through chemotherapy for about a year and a half. She asked me to help with his care because he really was starting to struggle these past few months. I did a video visit with him, actually made a house call on him. Lovely man. We did a few things to try to help him feel better because the chemo was really bringing him down. He was very nauseated. And so we did some symptom management stuff. Temporarily, I think he felt a little bit better, but I just couldn't get him feeling as good as I'd wanted. And lo and behold, his next PET scan shows that his cancer has just really dramatically progressed. And the way our American healthcare system works is the next step's just gonna be more chemotherapy. So that was just automatically where the inertia was taking him. He was just going to go and start chemotherapy again, but now in a much weakened condition from where he began a year and a half ago when he did okay with chemo early on. So I went to his house and he said to me, he said, I know it's progressed and I don't know why, but I'm doing chemo on Tuesday. And I said, Can we talk about that a little bit? He said, "Well, yeah." And so it led to a long conversation of I was trying to listen to his rationale for why the next step just had to be chemo. Like there was almost no other alternative to get off that railroad track. And I just told him, I said, "You know what? I think we all know where this plane is headed. And it's just a matter of what you go through before you get there. I want you to know that it's okay if you don't want to do any more treatment." When we talked about the alternative, and in his case, we talked about if you could envision the best end of life experience possible for yourself, if you could envision what that looks like for you, where is it? And what are you doing? Who's there with you? And he said, "Well, I would be at my house." He really wanted to be home and he wanted his family around him. I told him, "I think we've got time to do that. I think you could still do that." What he really feared was just going through more sickness, going through more toxicity, ending up and dying in a hospital, which was really something he was at risk for because he was very frail. I think his whole family didn't want to necessarily admit it to themselves or him, but they were really worried that he just wasn't going to be able to withstand chemotherapy. I left him that day and I got a text from his daughter the next morning and she said, "Dad woke up this morning. He ate fried chicken. He hadn't been eating for weeks. He ate fried chicken and he said, 'I'm going home.'" They went to their oncologist that morning and told them, "Thank you, but we're not going to do any more chemo." He went home with hospice. He had a good week and then a little bit of a tougher second week, and he just died about a week ago. It was about a 2-week experience, but he was able to be home and he was able to see all of his old friends. I know it's a sad ending, but he knew from the time he was diagnosed that that was going to happen. Sometimes giving people permission to say, "I want to do something different," can be, I think, a good experience for the family and the patient.
Thank you for sharing that story. It's really touching, and I'm sorry to hear about your friend's loss. I'm sure she's very lucky to have you to guide her through that and her father. And that same note of advice you would give to someone who is entering into the palliative care space with either a loved one or a family member, what can they do to care for their loved ones and themselves during this vulnerable time for them?
Don't ever be afraid to talk to palliative care. If your physician's recommending it, it's not an insult, it's not giving up. I think sometimes people feel like, well, they're calling in palliative care, they're giving up. No, it's really offering an extra kind of layer of support to help you through a tough time. Be willing to listen yourself to what the physicians are saying. You don't work this hard to get through medical school because you don't want to take care of people. We all have your best interest at heart. We don't control every aspect of our lives. This time is going to come for all of us at some point. It's the way we take that journey that matters. I think being willing to think about palliative care and at least know that it's just a conversation, it's not a demand that you make certain decisions. Be embracing the idea that palliative care can actually be helpful. And then if you're a caregiver, know that that is hard work. Oftentimes, we fail to recognize that those people at the bedside of their loved one, they're the true heroes. Being a caregiver is hard. It's an under-recognized role, especially in our country where we don't have a lot of resources to support people. Even with hospice sometimes, and hospice is a wonderful thing, but they're not there 24/7 in the home. It's the caregiver that's doing a lot of work. Caregivers need support too. I think if you're a caregiver asking for help from family or church friends or community is something you need to do to give yourself a break from time to time. Caregivers needing to take care of themselves is very, very important.
I was wondering that while you were talking about how this line of work has changed your own view on how to deal with end of life discussions, but then also how you yourself kind of take care of yourself and stay resilient in this line of work.
Every
Big
day I'm
question.
confronted with the fact that, anything can happen to any of us at any time. Love on the people that you love on. Make sure that people know how you feel about them today. Don't wait to do that because I see horrible, tragic accidents happen to wonderful people. I see people stricken with cancer at way too young of an age. My experience has led me to have a certain philosophy about the way I live my life. Any of us who work in healthcare have got to take care of ourselves. You can't give of yourself to others if you're running on an empty tank. I take every vacation day the hospital will give me. I have a healthy way of disconnecting from my work so that I can be a presence for my family and keep myself healthy. I exercise a lot. I swim. I
Good.
do like some competitive master swimming, which is a little bit crazy, but that's sort of my therapy for myself. So when I say I get up early, I get up really early and swim usually 3 mornings a week with my swim friends. To be resilient and to be able to do this for a long time, you've got to be able to have some distractions and a way to shut off what's happening at work when you're not at work. I would advise anybody if you're going to be happy in medicine. I've been doing this for almost 20 years now in total. You got to be able to turn it off. You have to have an on and off switch. And that's hard at first, but you get better at that over the years.
I think that's great advice. It's interesting that you swim. I used to competitively swim in high school and when I was younger, so I'll have to connect with you to get back in the game,
Crawfish
maybe.
Aquatics, we have a great master's program anytime, 5:30 in the morning.
Yes, I love it. Just to learn a little more about you, more of a fun question is what are you listening to these days? It could be anything fun or professional, but what's on your soundtrack, on your playlist?
I'm getting back into more mainstream country music. I love the Allman Brothers. I like Chris Stapleton.
Mhm.
I like the Bottle Rockets. I like just bluesy country music is what I really like. But if I read to you what's on my playlist, there's some embarrassing things on here too. There's some Taylor Swift, but some of that's just because my kids have gotten me into that.
Yeah, that's fun.
What do you see coming in the future for palliative care medicine?
There's a term called the silver tsunami. So, what does that mean? That means there is going to be a huge number of baby boomers who are not even 80 years old yet that are coming our way. My parents are baby boomers, they're 75 and 74. That's a huge population of people. And with the fact that we are all living longer and longer and longer these days, we're about to have a large influx of elders who, at this point in their lives, have serious illness to some degree. And yet they're living a long time with these serious illnesses. The role for palliative care is only going to get bigger and bigger and bigger. So, see serious illness care, the hospital entering more into the home setting to try to
Mm,
help provide more care to the patients so that they can sort of stay out of this revolving door in and out of hospitals as they experience complications. We're responding to that the best we can. We're actually starting a fellowship program here to train a hospice and palliative medicine person each year. So we have more providers in the community to take care of the population coming our way. I think that's exciting. It's just something we've got to brace ourselves for and try to prepare our other clinicians like primary care docs and critical care docs to manage too.
Dr. Raven, thank you for sharing your story with us and your advice. Is there anything that we miss that you want to cover or that you, like the one thing you want our listeners to know before we wrap up?
Sometimes acknowledging our mortality, it's always hard to do, really. But
Mhm.
I think if we keep in mind that everybody, no matter who you are, there's going to be something that happens to you. And we can either pretend that's not there, we can crash and burn, or we can have some sort of plan for what we want for ourselves. Think of it as important as buying life insurance, right? We don't buy life
Mm,
insurance because we want to die. We buy life insurance because we want to protect our families if something were to happen to us. And in a lot of ways, it's an unselfish gesture to have conversations with the people around you that you love about what you would or would not want. Believe it or not, you're doing them a service because if they're called to the table, they'll at least be armed with some information.
mm.
So don't be afraid of it. Just consider it part of your responsibility and don't be afraid of a palliative care doctor. We're usually all super nice.
That's good advice. That's great
Yeah.
advice. Well, thank you so much for joining us, Dr. Raven. We really appreciate this.
Thank you for having me. I appreciate it.
Listeners, thank you for tuning in. We'll have helpful resources linked in the show notes. Be sure to subscribe for more episodes of The Doctor Will Hear You Now, a podcast from Franciscan Missionaries of Our Lady Health System.
And if you have ideas for topics you'd like to hear on the show, email us at podcast@fmolhs.org. Thanks for listening.